Hello and welcome to this video on drug ads. This video is drug ad 2 in our part of our series on biostats and epidemiology made easy. So now let us get into it. Just like this, in the last video, in our last video on drug ads, the drug ad number 1, I told you how to approach a drug ad, and we're going to repeat the same thing in drug ad number 2. So without any delay, first of all, you're going to see that this is a drug ad question, and you're going to skip directly to see if there's a vignette with this question, a clinical vignette, and surely there is a vignette with this question. So first of all, let us read the clinical vignette, which is a 68-year-old man with hypertension, type 2 diabetes, chronic kidney disease, EGFR 58, comes for follow-up. He's currently on lisinopril and amlodipine. First of all, you want to make sure that you want to know everything about this clinical vignette that is important. So this is a patient with hypertension, type 2 diabetes, CKD, EGFR 58. He's on lisinopril and amlodipine, but recently saw an ad for Cardionics. So this is our medication that emphasizes its ability to cut down stroke risk nearly in half. The ad also claimed that the drug is well tolerated and effective across multiple outcomes. His physician looks up the GUARD-1 trial before deciding. And let us look at the question 1 and see what are the options. Which of the following best describes, and you're going to do this really quickly. You're going to read the clinical vignette really slowly. You want to understand everything that the patient has. Something that I used to do in my own time is that I used to write, this is DM2, CKD, and GFR 58. And what we're looking for is basically stroke risk in half. This is everything. You can, during the USMLE exam, you'll have a small paper, you'll have a small pen with yourself, and you can write it down, whatever you want to write down. So this is what you want to write down. And this is a patient who is a 68-year-old man. So this is everything you want to know about this clinical vignette in particular. Right. So and then you're going to get to the questions. You're going to read them really quickly. So which of the following best describes the company presentation of stroke reduction? Company's presentation of stroke reduction. The relative benefit odds ratio 0.57 overstates the absolute risk reduction. The unadjusted odds ratio is invalid because of non-significant p-value. So they're talking about stroke reduction as an outcome, and each of these outcome is basically talking about this odds ratio. The adjusted odds ratio makes the benefit clinically meaningless. So just from reading this question, you can just tell that there's an unadjusted odds ratio and there's an adjusted odds ratio. We're going to talk about what is adjusted and unadjusted. And stroke was not a primary outcome, so the result is uninterpretable. Just if you read this question, you will know that this option is completely wrong. Why? Because even if something is not the primary outcome, does not mean that the result is clinically meaningless or statistically meaningless. So this is going to be the wrong option, just reading from here. The result cannot be trusted because it wasn't statistically significant. So this is basically the same thing as B. So B and E are the same. So when we look at the p-value and when we look at the confidence interval, you can directly rule out or rule in B or E. And we can just look at this question. So our outcome that we need to look at is stroke reduction for the first question. So just going through this really quickly. Cardionics, vesicular target the pressure, shield the heart. Cardionics significantly reduces cardiovascular risk and offers superior blood pressure control compared to standard therapy. In the GUARD-1 trial, it was associated with a 42% reduction in stroke and a 33% improvement in heart failure outcomes. So they're claiming a 43% reduction in stroke and a 33% improvement in heart failure outcomes with a favorable safety profile. What is the mechanism of action? We don't care about the mechanism of action. What's the GUARD-1 clinical trial summary? Randomized, double-blind, multi-center trial. They have a huge sample size, which is 6,400 people. They're adults age 50 to 80 with hypertension and high cardiovascular risk. And the intervention is our medication versus lisinopril, which is the standard therapy. The patient is taking this currently, as we know, along with amlodipine, and our follow-up is 2 years. So the first question was focusing on stroke risk. Let's just focus on stroke risk for now, because everything in this question was about stroke risks, the unadjusted odds ratio and the adjusted odds ratio. First of all, let's look at the p-value. Is the p-value less than 0.05? Yes, it's less than 0.05. So good, it checks that box. Let's look at the unadjusted odds ratio. Is the unadjusted odds ratio, does the confidence interval include the null value or the 1 odds ratio or risk ratio or a hazards ratio? The null value is supposed to be 1. And if your confidence interval includes 1, that means it's not significant. In this case, it does not include 1, therefore it is significant. So if you look at adjusted odds ratio, what is the difference between adjusted and unadjusted odds ratio? There is a star here. What are they adjusting for? Well, they're adjusting for age, sex, baseline blood pressure, CKD and diabetes. Our patient has both CKD and diabetes, so they're adjusting for that, and our patient is 68-year-old, so they're adjusting for that as well. So they want to exclude. What does adjust mean? You want to exclude the effect of the confounding. Exclude the effect of confounding, such that the effect that you're seeing is not being caused by anything else than the intervention that you're studying. So adjusted odds ratio in this case, if you see, the confidence interval for this also does not include the null value or the value of 1 and is 0.63. So that means both the adjusted odds ratio and the unadjusted odds ratio, they're both significant. They're both significant. So that just directly rules out the option B and E. We'll go back and we'll go talk about it. So let's look at the risk for in both of these groups. So it's 3.8% in the vesicular group and 6.4%. That means standard therapy has a higher risk for stroke as compared to vesicular. So let's go back to our options and let's rule out a couple of things. So which of the following best describes the company's presentation of stroke reduction? But right off what we studied, we can rule out B and we can rule out E. Stroke was not a primary outcome, so the result is uninterpretable. I told you this is completely wrong. The adjusted odds ratio makes the benefit clinically meaningless. Well, that's not true. The adjusted odds ratio in our case was still 0.63. Which is like a huge improvement. It's not like it's 0.95 or 0.97, which is very, very close to 1. So this is not clinically meaningless. This is not clinically meaningless. So what's the company's representation of it? So the company says that this is associated with the 42% reduction in stroke. 42%. Where did they get this 42% number? Well, they told you the relative risk reduction. They told you the relative risk reduction, which in this case is higher risk minus lower risk divided by baseline, or in this case lower risk, which becomes 42%, which becomes 42%. So they're telling you the the relative risk reduction, the RRR. Sometimes in drug ad questions, what they will tell you is the relative risk reduction. You will think this is a huge improvement, but what in fact they're doing is that they're giving you the RRR. So in this case, A is the correct option. Why? Because the company, what they're doing is that they're telling you the relative risk reduction, and that is overstating the absolute risk reduction in this case. What is the absolute risk reduction in this case? Let's open our calculator. So what is the relative risk reduction in this case? And they overstate the absolute risk reduction. This is what they do. They overstate the absolute risk. If you just minus the higher risk from the lower risk, and you'll get the absolute risk reduction. But what the company will give you is the relative. They'll give you like a huge number in percentage. So in actuality, even if your result decreased from 0.9 to let's say 0.5, they'll give you the relative risk reduction, and they'll tell you this is like a 40-50% reduction in risk, which is not actually a lot when you look at it clinically. But in this case, the option A is correct because they give you the relative risk reduction. So let us read question number 2, which is which one of the following conclusions about hyperkalemia risk is most accurate? The unadjusted odds ratio underestimates the true risk due to confounding. Okay, I mean it can be underestimates or overestimates, we don't know, but this can be true. The adjusted odds ratio shows a significantly increased risk even after correcting for baseline CKD. Okay, the lack of statistical significance suggests that the risk is negligible. So if the result is statistically significant, this option will be completely wrong right then and there. The high unadjusted odds ratio is misleading and likely due to random error. So when we talk about unadjusted and adjusted odds ratio, what we are adjusting for actually is confounding error, not random error. So this is completely wrong right here. the NNH or the number needed to harm is greater than 100, suggesting a very rare adverse event. So I think something that we should do right away is go and calculate the number needed to harm so we can rule out this option. So let's go and look at hyperkalemia. This is the hyperkalemia risk. So it's 6.1 in the vesicular group and 3.2 in the standard therapy group. So something that we can see is that the risk for hyperkalemia is higher in the vesicular group. So this will be number needed to harm, or if you look at the unadjusted odds ratio, this also represents what we exactly just saw in the risk, which is 1.97. That means there is a higher group in our higher risk of hyperkalemia in our intervention, which is with the odds ratio 1.97 with the unadjusted. And when you adjust, what do you adjust for? Well, you adjust for age, sex, baseline blood pressure, chronic kidney disease, and diabetes. You get a value of 1.81. So it gets slightly decreased. And then you have the odds ratio, which is of course less than 0.05. So it is still very, very significant. So something that we can rule out just right here is basically this option is wrong because the risk is not due to random error, and in an unadjusted ratio it's due to confounding error. It's due to confounding errors. Let me write it down. The lack of statistical significance is wrong because the result that we saw had a p-value less than 0.05, and the odds ratio also did not include the value of 1. So this is also wrong. The adjusted odds ratio shows a significantly increased risk even after collecting for baseline CKD. So this is kind of true. Let's look at the other options as well. The unadjusted odds ratio underestimates the true risk due to confounding. So that is not true. It actually overestimates the risk. If you go back and look at the values, so the unadjusted odds ratio was giving you 1.97, and when you adjust the confounding, it gives you 1.81. So it was overestimating the risk due to confounding. So that's the problem with this particular question, with this option, because it's overestimating, not underestimating. And then let us look at the final, which is the NNH, or the number needed to harm, is greater than 100, suggesting a very rare adverse effect. So let us calculate the number needed to harm. So this is how I solve the questions in particularly drug ad questions, so that I get I rule out every single option one by one, and until and unless I get to the final correct option. Because sometimes when you look at the options by themselves, all of the options may seem very, very confusing, but you need to rule them out one by one and get to the confusing one, get to the ones that you don't understand, or get to the ones that you think might be right in the end. So hyperkalemia risk, we want to calculate the number needed to harm. For this, if you've seen my video on number needed to harm, you will know that to calculate number needed to harm, you just minus 3.2 from 6.1. What you'll get is this basically, which is the absolute risk increase. This is the risk that is increased in the vesicular group. And what you do is that you divide 1 by 2.9. Whatever value you're getting here, just divide 1 by it. So instead of 2.9, because this is 2.9%, you will get 0.029. So what you do is that you will divide 1 by 0.029. So let me correct this. 1 by 0.029. So how I got the value of 0.029? So I just minus the smaller risk, which was 3.2% in the standard therapy, from the higher risk, which is 6.1%. I got 2.9% or 0.029. And what I got, how do I calculate the number needed to harm from it? I just divide 1 by 0.029. And now what am I getting? I'm getting 34. So I'm not getting exactly the value of 100 that they're saying. So that option is also wrong. So they said that this value is greater than 100, which is also wrong. So let's just say this option is also wrong. So what do we get? The adjusted odds ratio shows a significantly increased risk even after correcting for baseline confounding. So this is exactly what happened. So earlier it was showing 1.97, then we corrected it, and it went to 1.81 or something like that. So this is the correct option in this question. So now let us look at question number 3, which is, which one of the following is the most likely reason that the compound cardiovascular mortality benefit was not significant? Composite cardiovascular mortality benefit was not significant, which is the most likely reason. The adjusted odds ratio eliminated all effect. Okay, we can go back and look at it. The baseline risk was too low to detect a difference. This basically means that the effect size is actually too small. When the effect size is too small, that reduces the power of the study. We'll talk about that in a bit, but let me remove it for a bit. The study had too few participants. Well, that's not true at all, because the study had something like 6,400 participants. So this is in fact the wrong option. We don't get a lot of studies with a very huge number of people. So 6,400 is actually quite a bit. The p-value of 0.71 indicates a type 1 error. Okay, I mean, the p-value does not indicate a type 1 error happening or not, but it just indicates whether the results are significant or not. So this is kind of a sus option. The event rate was higher in the treatment group. So let's look at it. What is the most likely reason? The composite cardiovascular mortality benefit. So we go back to our question and we go back to composite cardiovascular mortality. And the risk in the vesicular group was 4.5% and 5.0% in the standard therapy. And when you look at the n-adjusted odds ratio, oh yes, if you look at the confidence interval, it includes the value of 1. It includes the value of 1. That is a problem, because that means this odds ratio is not actually significant. Let us look at the adjusted odds ratio. That also includes the confidence interval. The 95% confidence interval includes the value of 1, which still means it's not significant. And then when you look at the p-value, usually when you're getting a confidence interval that includes the value of 1, you will not get a p-value that is less than 0.05. Just remember that for the sake of your U-word questions. So this is 0.71, which is also not significant. So why is this not significant is what we wanted to take a look at. Let's go back to our options one by one. And our options one by one was the event rate was higher in the treatment group. Was the event rate higher in the treatment group? Well, no, it was not. It was 4.5% and 5.0% in the standard therapy. So the standard therapy group actually had a higher risk. So this option is wrong. This option is wrong. The p-value of 0.71 indicates a type 1 error. No, that does not indicate a type 1 error. This is completely wrong. A p-value of 0.71 indicates that your results are not significant. The probability that type 1 hypothesis is actually, the probability that the null hypothesis is actually correct is very, very high. And these results that you're getting are actually due to this amount of chance. This is how you interpret the value of p. So this is wrong. This is also wrong. And then if you look at this, the baseline risk was too low to detect a difference. So let's go back whether this is true. So the difference between 4.5 and 5.0% is actually very, very small. And why is that important? When you get insignificant results, when you fail to reject the null hypothesis, when it is wrong, what does that depend on? That depends on the value of power. How powerful is your study? Basically, when you're doing a study, you want to prove the alternate hypothesis true. And what do you do for that? Well, you get a study with a huge sample size. Well, you get a study with a high level of significance. Basically, you want something like 10% level of significance. So if there is a difference, it gets very easier to detect. It gets very easier. The smaller the level of significance that you get, for example, if your study has let's say 1% level of significance, you want 1% level of significance, your power actually decreases. So you want the level of alpha, you want the value of alpha to be very, very high. You want alpha to be high for you to have higher power, because whenever the level of significance increases, it gets easier to detect a difference. The power increases. So you want alpha to be high for power to increase. And the third thing, you need to watch my video on power to understand this completely. I've made a complete video on power. And the third thing that it depends on is actually effect size. I give this example in my video on power. I'll put a link up there. It's easier to find a huge red ball in a haystack than it is to find a needle in a haystack. So if the difference between the standard treatment and the vesicular group in this case was of, let's say half, like 2.5% minus 5%. So this was a huge difference. But in this case, it was only a difference of 0.5%. In our case, it was only a difference of 0.5%. So this option might actually be the correct option, because this is decreasing the power of our study. The effect size in our case is very, very small. And then the adjusted odds ratio eliminated all effect. Well, that is not true, because even the unadjusted odds ratio did not have significant results. Even the unadjusted odds ratio did not have significant results. So that is what I want you to remember from this question. That's why this right here is the correct option. This was the correct option. So now let us look at the question number 3 in our study. Now let us look at the question number 3 in our drug ad question. This is actually a slightly more complex question, and what I want you to understand before we go into this question is this one thing. What is p-value? How do you interpret p-value? Whenever you have a p-value of, let's say, let's say you have a p-value of 5%. If you have a p-value of 5%, that means that there is a 5% chance that the observed effect that you have, observed effect is not real, and due to chance. There is a 5% chance that this observed effect that you got is not real, and this is due to chance. Just understand this, that whatever results that you have is not true. That's why whenever the p-value gets smaller, that means your results are very, very significant. So now let us get into this question. In the question number 4, we have, in the GUARD-1 trial, cardionics achieved a stroke reduction from 3.8% of patients to compare to 6.4% in the standard therapy group with a p-value of 0.001. Which of the following best interprets this result? This result is likely due to chance and not clinically meaningful. Well, that is not true, because the value of p is actually very, very small, and we set a value of, let's say, 0. In most cases for your exams, it's going to be p of 0.05, and it's way smaller than that. That means this option cannot be true. This is not likely due to chance, and it's definitely not clinically meaningful. There's a 0.1 chance that the observed effect difference is real. Well, I just told you that whenever you have the p-value, this is the chance that the observed effect is not real and due to chance. So that's why this is actually the opposite. They have written the opposite of it, that there is a 0.1% chance that this result that we got is not real. That's why this is actually false. So the difference is statistically significant and likely not due to chance. This might be the correct option. Let us look at the other options beforehand. The result indicates causality between the treatment and the outcome. Remember, because you cannot establish causality with the help of this one single study. There is a whole criteria for causality, the Bradford-Hill criteria, in which there is a lot of associations that you need to establish. There's like the dosing, that what amount of intervention. So there's a lot of things that go into establishing causality. Usually whenever you get causality in the question, whenever you get causality in the drug ad, remember that this might actually be the wrong option, because there is a huge criteria that you have to meet for causality. So this is not the correct option. The study failed to demonstrate non-inferiority. Well, non-inferiority is a very particular concept, and non-inferiority trials are conducted in which you establish whether the study was whether this intervention was better or just basically not worse than the existing trial. And this is not a non-inferiority trial, so you cannot say things like this. So our correct option in this case is that the difference is statistically significant and likely not due to chance, because the odds of this being due to chance are actually 0.001 or actually 0.1%. So this is the result of our study. So in the end, if you haven't watched my series on biostats and epidemiology, I would suggest to actually go back. There are like 18 to 19 videos. In each one of these videos, I explain what are the important topics that you need to study. I explain each topic with sample questions, mnemonics to help simplify these topics for you. This is the second drug ad. If you haven't watched my video on the first drug ad, I would suggest go back and watch it. Thank you so much for watching.